underneath the fillings. As we look at the actual exam, you can see a hole in the filling where the patient has ground down the tooth and on the second molar, and then you can see some erosion where the enamel actually is worn away on the cusp tips of the first and second molar. As we get closer, you can see the wear that's occurred and possible chipping of the tooth. So there's multiple problems that has caused this particular restoration to fail. The first molar also has that erosion, as you just saw in that picture, and we go ahead and remove the tooth-colored filling. And as we start to do that, you'll notice the dark brown that's there and the softer decay that shows. Now you have to ask yourself, well, was this all just from grinding? And it's possible that the filling had loosened up, but you have to also think that possibly the bonding of the material might not have worked. That's very difficult sometimes. These fillings are actually 4 years old according to the patient. He's a new patient to my office, and if you went back and looked at the x-rays, you could see possibly the decay up underneath, or it could have been a liner. That's one of the problems with tooth-colored fillings. The reason we did go ahead and do it was this interproximal decay that's very obvious with the white filling there, not filling, but decalcification that goes in between the teeth. And if you notice, it is a broad approach all the way there. And then the adjacent tooth also has decay. And in a few minutes, I will start removing that in a very conservative way. Here I am. And because I have access to the side of the tooth, I can go ahead and just remove that portion of it. As we get closer, you'll notice that behind the white area that there's a little bit of brown decay where the bacteria had penetrated. And this particular drill that I'm using is called a 330. It's a very small head. And now we're going to switch to a round burr that is able to remove some of the composite that's still there and to remove the obvious decay. You will see with the a little bit later how the decay is actually up underneath the cusp tip. And we use a spoon to show that the decay is still there. It's very soft. We're able to peel it out. And teeth are supposed to be hard, not soft. And so we have quite a little bit more work to do. And it's possible that the filling may have had some decay left behind originally. That would be another alternative. It's possible that the light didn't cure properly. So you have actually about 4 or 5 different reasons. One is the patient's bite loosened up the filling. 2 is that the bonding didn't work out the way it should, either from the manufacturer defect or possibly the light not curing it in the proper direction. The 4th might be that there was some decay inadvertently left behind by the previous dentist. There's just a lot of different possibilities. Contamination from the saliva. We need to be able to keep it nice and dry for the bonding. Now here I am putting in some decay detector, and I'll usually do that once just to kind of get an idea if I'm missing anything. As it gets deeper, the decay detector isn't quite as effective, but you can see the lots of green indicator on the second molar and how deep that is, and not quite so much on the first molar, but it's still there. And so we'll go ahead and remove those areas, and then open up the tooth, particularly on that second molar, so that the light can penetrate up underneath the cusp. I'm not an advocate of silver fillings, but if you were able to get all the decay out, you wouldn't need to necessarily remove all the undercuts with a silver filling. On the other hand, with a tooth colored filling, you definitely need that to happen unless you're using some sort of self-cure composite. And here we are opening that up a little bit, and we still have a significant amount of decay there. And the whole idea is to remove it all. And you're just getting the highlights of this particular tooth fillings. It certainly took longer than 10 minutes to get this all cleaned up. And you can also see in this view the cavity preparation on the mesial. And now we're switching over to the first molar, making sure everything's taken care of. Notice how I'm using a mirror to see into the tooth and drilling at the same time. So it's not direct vision. And sometimes people, dentists, will remove the decay only from the one view and not use a mirror, and that makes it more difficult to get all the decay out. And there's still some decay, so we go ahead and remove that. And this is relatively deep. We're going to put some sort of base down, which is a liner to help the nerve not be quite as stimulated, and to make it more comfortable so that the tooth doesn't lose vitality. There's a little piece of cord that's packed between the teeth, and that's so that we can get isolation. We can see a little bit of the white area that was still there. I went back and removed it. Here I'm putting the base in, and that's for the second molar. Here it goes for the first, and we'll light cure that to make that nice and hard. Now, there are folks that really like to say, okay, use a rubber dam in a situation like that. And I found that with a microscope in my particular hands that over 30 years, I haven't had problems with leakage where I've had to go back and redo things. Here I am polishing the interproximal area with a soft flex disc just to make sure everything's nice and polished. If you notice, it's not bleeding after that, and that's because of the cord that was there, and I was able to make it really, quite nice. Just a little bit of oozing there after that, and but not significant enough once we put a band around the adjacent tooth. And you'll see that, I think, in just a second. Okay. And tooth number 20, the decay got so bad that she sought to seek dental care after 10 years. Now, with all the decay in her mouth, she really doesn't have very many options. It's possible to pull some of these more extensive, or extract some of these more extensive teeth and make a partial, or do some sort of other restorative work. But she really doesn't want to change her habits in terms of having sugar every day. In her mind, she needs to have that. So other options would be to pull or extract all those teeth and possibly the implants and make a lower denture. Usually you'd like to try to incorporate the implants into the denture. Having them in the back portion of the mouth makes it very difficult to do that, and we'll probably need to place some implants further forward. If we were able to place 2 implants or 3 implants further forward, it's possible to do a teeth in a day type scenario where the teeth are pulled, the implants are placed, and in that day the temporary denture is screwed down to the implants. 3 months later, after the implants or after the healing has occurred, a hybrid denture could be made that would be screwed down and basically allow her to continue having her sugar every day. One of the, now that's not good for the rest of your body, by the way, but that would allow her to not to have as much maintenance. The three different choices then would be try to restore everything again, pull the bad teeth, and either do partials or crowns and bridges off of the implants. Do just a regular denture, which would actually be the least expensive way to do it, but you'd either not use the implants or you would use those as like an overdenture type thing, or try to clip it in. Being in the back area, that's usually not the location and may cause some problems with doing the lower denture. This is tooth number 20, where she originally came in with the pain. And then the third alternative is the 4 or 5 implants where the teeth are screwed in at one time. She was just very disheartened. This is the upper denture, by the way, that was done 10 years ago. Very disheartened and just decided to stop going to the dentist. No matter what, even with the new work that's going to be done and